Well, hi everybody. I'm here today with Rachel Murray. She's with Atrium Women's Sexual Health and Wellness. We are NothingPink, an organization that is dedicated to providing awareness about hereditary cancers and helping women who are at high risk. We're here today to talk with Rachel about women's sexual wellness and for women who are previvors and survivors about some of the common side effects from treatments and what we can do to make the symptoms better. So,
question: am I looking at you all?
I'm going to look at the camera. I'll
Okay.
edit this out though.
I'm gonna look at the camera. Okay, great.
Okay, so tell me a little bit about what kind of care you focus on.
Okay, so we work with, I'm going to talk about two subsets. One is menopause. So menopause is considered 1 full year of your period, and then we also work with perimenopausal patients, which is the 10 to 14 year period prior to menopause, where symptoms start to change. And that matters for women who have breast cancer, women who have gone through treatments, and women who are diagnosed with a mutation that might make them more susceptible to certain types of cancer, because a lot of these treatments that women are doing, whether it's chemo, radiation, the aromatase inhibitors, tamoxifen, hormone therapy of various sorts, can essentially throw us into a state of menopause and end up causing a number of symptoms that are related to sexual medicine. So the other part of our office is full scope sexual medicine, which is a really exciting emerging area of medicine that has been around for many, many years, but is continuing to gain headway. And this is the focus on low libido, painful sex, decreased ability to become aroused. So that's the sensations that we feel, the lubrication that we experience, nipples becoming erect, goosebumps on our bodies, lack of ability to orgasm.
Okay, great. That's a lot of
It's a lot of stuff.
Yeah, it's a lot of
Lots
stuff
to talk about today.
Yeah. So if somebody comes to see you, what does a typical first appointment look like?
Sure. So when we have our initial appointment, the first thing that is really important for women to know is that we have a small office, and everyone in our office is extremely passionate about menopausal care and sexual medicine. So everyone who walks into our office, you're going to meet people who love what they do, who are there to make women feel comfortable. I ask every single woman at her first appointment how she's feeling being there, because some people feel really, really confident being there and comfortable, and some people, it's a huge step to walk into an office that's called a sexual medicine office, right? Our new patient visits, as of right now, are 60 full minutes, and the reason that we get those longer appointments is because we take what we call a biopsychosocial approach, where we're really looking at not only the medical conditions that a woman may have or what we're assessing or what their symptoms are, but we're thinking about what they're going through psychologically, what are the thoughts that they're having, and then also psychosocial, or sociocultural, meaning how were they raised, growing up talking about sex, what's going on in their relationship at home, is there any history of sexual abuse or any type of abuse that could be impacting, for example, their ability to orgasm. So we talk about everything in a woman's life. It's not just about what is your condition and what are we going to do to treat that condition. We offer, when it's necessary, we are going to do a physical exam, and we tell every woman she is in control of that exam, especially for someone who's been going through pain. I don't want to just say to her, okay, we're going to do a physical exam, and for her to feel a sense of a lack of control. But we do want to do that exam, and it's very thorough. We're looking at, a lot of people think about the vagina, okay, I'm going to go to the gynecologist and they're just going to examine my vagina. Well, we're looking at this in different areas. So we focus on the clitoris, we focus on what we call the vestibule, we focus on the vulva, we focus on the vagina is actually where a penis goes, right? It's inside, it's a tube. So we're looking at all of those areas in a very thorough way to make sure that we're assessing all of the potential physical areas that could be causing pain for a woman. What? Am I allowed to say these words? Am I allowed to say these words?
I just have 3 boys, and
I cannot say these words. We can.
no, you can totally say them. I'm just trying.
Okay.
I'm just trying not to laugh.
Y'all should see the books that I have in my house for my little boy and my little girl. My mother-in-law just
we can't even say balls in our house without snickering.
Oh, we talk about the vulva.
Yeah.
We just, My
I
she has a vulva.
I guess my future as a newscaster is not.
Just come work in sex sexual medicine.
I'll get
Everyone's comfortable with
desensitized to
these
it.
things.
Okay, anyway.
Happy birthday.
Thanks.
Is that your birthday?
It is my birthday.
Oh, it's really your birthday. Sometimes I say that to people and I don't mean it. Happy birthday.
Thank you. Anyway, now we've broken some tension.
Yep, there. It's all out there.
All right, so anyways, I'm sorry for that. But
No, that's good.
all right, so we'll move to the next question. So let's talk about the previvors and survivors. So many of our women have had breast or gynecological cancer or surgery to either reduce risk or remove cancer, and then a lot of them have endocrine therapy or hormone replacement therapy.
Yep.
So these treatments obviously have side effects that women are dealing with. And can you talk about like what they most typically are that you see coming through your office?
What are the treatments that women are getting?
What
are the side effects that people are getting from
the side effects? Yes, the side
okay.
effects from the treatment.
Cool.
Mm-hmm.
So, going back to what I touched on earlier with menopause, the various things that we see women being treated for, most of you are going to know this, right? We look at chemotherapy, we look at radiation, we have women who are on medications that essentially take their hormone levels down to zero. So the short of it is we see menopausal symptoms. And what do we see when women go through menopause? Well, of course, we see hot flashes, night sweats, cognition changes, fatigue, anxiety, joint pain, you name it. But in addition to that, we see lower libido, decreased arousal, and this can impact relationships, right? Because oftentimes partners process that as you are no longer excited about me or you're no longer attracted to me, which isn't necessarily the issue. We absolutely see pain. And that is because we have estrogen receptors throughout our entire body, and the vagina and the vulva is no exception to that, and the vestibule. So those receptors essentially get sucked up and are no longer active, which leads to a significant amount of pain at the tissue. And that can also affect the muscles because we have receptors in those muscles as well, in our pelvic muscles as well. So women can have even more pain on top of that. And we see women suffering this for years before they get to us. Oftentimes. Vaginal dryness is very, very common because again, those receptors aren't working. And so the body is not responding in the way that we would expect it to. And in some cases, women can actually feel like they want to orgasm too often, and that can also potentially be a response of that lack of hormone.
Okay, all right. So I did not know that actually.
Yeah.
So low libido is something that we talk about a fair bit within our group, and you just
Cool.
touched on it. But
Yeah.
can you describe a little bit more, kind of about like what it is, and then
Causes
and
all
how
things.
we can treat it?
Yeah. So low libido is tricky. Low libido is decreased desire for intimacy, and if you don't, so it's the want to have sex. It's not about becoming lubricated or being able to orgasm. It's only about, do you have the desire to have sex? If you never had desire for intimacy and you come into our office and you say, I don't have desire for intimacy and I don't really care and I never did, it doesn't matter. We're not worried about it. There's nothing medical that I'm concerned about in terms of libido that puts a woman at risk for anything, but it's a quality of life issue, right? And so when we think about low libido, it's a little, we don't exactly know why it happens. There's brain system activity that we're looking at, and we're looking at balance of what we call excitation and inhibition, and that's related to hormonal activity that essentially activates certain neurotransmitters, so chemicals in the brain, communicators in the brain, that are excitatory or inhibitory. So for example, dopamine makes women want intimacy. Norepinephrine is a neurotransmitter that makes women want intimacy, whereas serotonin is a neurotransmitter that tends to be more calming and makes people not want intimacy. So let's say, for example, a woman is diagnosed with cancer and then she has higher anxiety and then she gets put on what we call a selective serotonin reuptake inhibitor, so an SSRI. That can be more inhibitory and really deplete her ability to climax and deplete her libido completely because it's an inhibitory neurotransmitter. So we're looking at the hormones, we're looking at the neurotransmitters, and then in addition to that, this is where that sociocultural piece comes in. And the psychological piece comes in. So we know that just from stress that women have in life, from various experiences that women have in life that can certainly be adverse, that can also affect libido and lead to what we call neuroplasticity in the brain and beliefs around intimacy, where women are experiencing lack of libido because they have pain, and so then of course they don't want sex. It's painful all the time, or they had this adverse experience with a partner in the past, and so they don't want sex because they've never had good experiences before. So that's when we're looking at all of the pathways in terms of what's going on.
Awesome.
Okay. And so as far as medications that can help with that, are there different ones or?
Yep,
okay.
totally.
Can you talk about
So biopsychosocial approach applies to our assessment of the situation, and then also looking at how we're going to approach and treat the situation. There are medications that work. Generally speaking, I always use the caveat that if there are other major things going on, I'm not going to start with medications. And that's not to say, like, cancer doesn't change that. So if someone has cancer or has a mutation that's making her more susceptible to cancer, and she's had her ovaries removed and she's going through this, we may still start medications. But if someone has severe depression and is in an abusive relationship and a number of different family stressors that are going on, then we may want to approach this more from a cognitive behavioral therapy standpoint first, prior to starting medications. And the reason is that the medications can't necessarily fix all of the other things that are also preventing her from wanting libido. But let's chat medications. So there are 2 FDA-approved medications for premenopausal women. One is called Addyi, which works on the serotonin receptors. It's actually works it's an agonist-antagonist, so it makes some of those receptors activated, some of them deactivated. But it can work. The efficacy on it, I think, is like 1 in 8. It was initially studied as an antidepressant medication, and it wasn't found to be statistically significant in that sense, but what they found was that women actually had more sexually satisfying events. And it can potentially help with orgasm as well and other areas of the sexual experience as well. It can make people fatigued, that is the one thing, and so we tell people to take it at night before they go to bed. And then some women, it just kind of makes them tired. It doesn't really do anything else. Then there's Vyleesi, which is, I call it like an EpiPen. It really is like a pen that you inject into your thigh 45 minutes prior to wanting sex. It can make you nauseous the first couple times you use it. So I usually tell women, I'll give like Zofran, an anti-nausea medication with it, just for those first few times to get through that. But it can definitely work and be effective. The efficacy on that one, I think, is 6 out of 10. I always tell people context is dependent. It's context dependent, so making sure you're not doing it on a night when you've got 3 kids at home and a huge presentation the next day, but doing it on a night when you can really relax and enjoy with your partner. And then there's Wellbutrin and Buspar, and these are, so thinking about those excitatory and inhibitory pathways in the brain. Buspar is a really good medication to use for women who just have a ton going on. Their brain is constantly moving, they're always thinking about what's next, they've got this new diagnosis and it's really stressful for them. Buspar can help take the edge off. It's not always 100% effective, but in some women it really, really works. And then Wellbutrin is working on that neurotransmitter. So it's working on norepinephrine to make women want intimacy more. The one thing I say is that it can increase anxiety. So if women are more prone to anxiety, then I wouldn't necessarily recommend Buspar. And then for postmenopausal women, which can be appropriate in certain contexts in terms of cancer, we can also use testosterone, because testosterone, especially in our BRCA patients which we can use hormone therapy in BRCA patients and BRCA patients. When we remove those ovaries, we sometimes see a 50% depletion in testosterone, which can significantly impact libido. So we can do testosterone therapy, and that's also appropriate with perimenopausal patients as well, so women in that transitional period when they're sort of going into menopause. And then we think about more of the psychosocial approach. So looking at cognitive behavioral therapy can be very effective. Sex therapy can be effective. And the reason is because we think about that neuroplasticity, right? We start to develop certain beliefs based on, I've had pain forever, I don't want intimacy, that's the last thing on my mind, or I'm really stressed, I have a number of other things going on. Sex therapy and cognitive behavioral therapy are working to look at those beliefs. What are they, where did they come from, and what can we do to change them? And how do we want to see ourselves sexually? There's also some good evidence on meditation. There's a researcher, her name is Lori Brotto. She has a book called Better Sex Through Mindfulness that talks about this a lot. And she has body scans on her website that I recommend to almost every single one of my patients. So she's got a bunch of body scans, but 2 or 3 of them are specific to intimacy. And it is thinking about your vulva, thinking about yourself sexually, and really trying to evaluate what you want that to look like for you. Okay, so we talked about sensei focus, we talked about meditation, body scans. I feel like I'm missing things, but those are the three big ones that I typically touch on.
Okay, cool.
So,
and we'll get that link from you too, and share that link for the website that you talked about, so that way people can go check that out.
Yeah.
And so then another thing, especially when women are thrown into menopause, is the pain during sex.
Yeah.
So so if you can touch on that, and what can we do about it?
Yeah.
Okay.
Pain during sex is a big one, and we see this all the time, and I think it's really also important to talk about in this context a condition called vulvodynia, which is constant pain, because that can absolutely also happen for women that are going through these treatments. So dyspareunia is pain during intimacy. Vulvodynia is pain that's happening all the time and then can sometimes be exacerbated with actual intimacy. The question was why it happens.
Well, what can we do about it?
What can we do about it? Okay, so number one thing that we can do about it is vaginal estrogen. And I know hormones sound scary in the context of breast cancer, but particular vaginal estrogen is considered to be very, very safe. It's not increasing hormone levels above that of a typical postmenopausal woman, right? And that's generally the concern, is that we're increasing those levels to a point that it's going to hit the receptors in the breast. So in this context, it's probably not going to happen. We are always, number one, going to make sure our patient is feeling good about her treatment plan, but also check in with oncology to make sure that they're okay with this. The one caveat to this is when we're on the aromatase inhibitors, it can be a bit controversial, and that's because the aromatase inhibitors are taking hormone levels down to absolute zero. That's how they work. And so a lot of oncologists don't want those levels to increase at all, and they would prefer not to do vaginal estrogen. So in that case, there is most notably hyaluronic acid. So there are various vaginal formulations of hyaluronic acid. Our body makes hyaluronic acid. It's very safe, but it's going to help moisturize the vaginal tissue and make it not postmenopausal tissue. It's gonna help with lubrication and all of those things as well. Pelvic floor physical therapy is a huge one, and I cannot say enough about our incredible pelvic floor physical therapist, Erica Warren. She's amazing. She works with patients in our office, but there are a number of pelvic floor PTs that are also great around the Charlotte, South Carolina, Fort Mill area. The pelvic floor gets affected as well with these treatments for cancer, and so basically the hormone receptors in that area are sucked up as well. But also, if women are having pain at the tissue, then they're going to guard and they're going to hold their muscles even tighter, which leads to what we call hypertonic pelvic floor muscles. And so we want to work with pelvic floor physical therapists to actually relax those muscles. Pelvic floor PT is a specific focus on the muscles in the pelvic floor. And so I always tell women there is certainly assessment and treatment of those external muscles, giving you exercises that you can just do on your own. But also there is some internal examination that will go on with the permission of the patient. So that's inserting fingers inside the vagina and really working on those muscles to help relax. So if this is my vaginal opening, I'm helping to relax. We're talking those terms again.
It's okay, I got it out of my system.
We're working on relaxing the pelvic floor with our fingers to essentially massage those muscles.
Okay.
So yeah.
So lots of options.
Lots of
options. Which is really encouraging,
yes.
Because
yeah.
You can treat it in more than one way.
Yeah, absolutely.
And so I think you mentioned this earlier, but so female orgasmic disorder is another thing that women will experience.
Yep.
So again, like a quick explanation, and then some things that we can do if you're having symptoms.
Sure. So female orgasmic disorder there's a number of things that sort of fall under that title, because there's an inability to orgasm completely, there's muted ability to orgasm, and then there's persistent genital arousal disorder, which is where women feel constantly aroused, which sounds like it could be great, but it's actually can be really debilitating and terrible, and lead to depression and inability to function. And all of these things can be a result of lack of hormone. So the number one thing that we're going to look at for women who have struggles with orgasm is their clitoris. There is a piece of skin over the clitoris in women that covers it. It's called the clitoral hood. And when those hormones go away, often the skin will stick to the actual clitoris and they start to have decreased sensation and cannot climax in the way that they previously could. So we can do estrogen usually very safely in these women because again, there's not going to be systemic absorption. In some cases we can do testosterone as well because we have testosterone receptors in that area also. What this is doing is trying to increase blood flow around the clitoris to increase that sensation, increase moisture in the area. And we can also do a procedure called lysis of adhesions where we are numbing the clitoris and peeling back on the tissue around the clitoris to open it up. So it's not 100%, but it can be very effective. It's an in-office procedure. Women don't need to be put asleep, but they are numb. They will feel stretching. They will not feel, there's no cutting, and they should not feel any pain when this procedure happens. So that can be a really effective option as well. And it was, It was treatments for orgasm, right?
Yeah.
So sometimes we'll even there's a cream called Scream Cream, which isn't super evidence-based.
Just comment on the Google chat.
Scream Cream is essentially, it's a combination that also uses Viagra that can potentially be helpful. I mean, we can certainly try it. And then things like Addy can potentially be effective for orgasm as well. So that's not going to be the first line that I use, but there are additional things we can bring in. And then also our sex therapy and our meditation and really tapping into that parasympathetic nervous system, that calming nervous system is going to be important. So that we sort of get back in touch with ourselves. The other conversation that's really important to have is, okay, have you always climaxed from the clitoris, or where did you used to have your climax? What are some other areas on the body that we can explore that might feel good for you? Because we have to remember we have erogenous zones, feel-good zones throughout our entire body that might lead to climax. So,
and so then we just did have a question pop up. I saw it. It is, do you take insurance? Yes. So this is part of Atrium. So yeah, they're within the Atrium umbrella. So yes, you just would make an appointment.
Yes. Mm-hmm. Yes. It's the same.
So another thing that pretty much everyone in this room can understand is hot flashes and night sweats and cold flashes after a hot flash, yes, right? Yes. So, we understand some of the reason why, but, what can you do to help with those? Yeah, and address that. Mm-hmm.
So I see a lot of women who come in and they also have thought, okay, there's nothing I can do for these hot flashes, and it hasn't been discussed, right? Because when we're going through these treatments first of all, oncologists are incredible, obviously, right? They're saving our lives, they're prolonging our lives, they're doing a lot of really important work. What gets missed sometimes is also we have a cancer diagnosis and life goes on after a cancer diagnosis. We can still live an amazing life and have a great quality of life. And we have a lot of women who think, I'm lucky just to be here, or I should just be grateful, which we are so grateful, right? But also it's okay to be upset that you're having hot flashes and that you don't feel good every day, or that you're feeling pain from sex. Like, we want to address these things too. You deserve to want that. So in terms of hot flashes, okay.
Thank you for saying that, because I think a lot of people, I just sorry to interrupt you, but
okay.
I feel like so many people, you're like, oh, well, like, my left hand doesn't work anymore, but I'm still here, so I'm just going to put up with it. And then also, I can't keep a train of thought, and my left hand doesn't work, but I'm still here, so I'm just going to put up with it. And so I think that that's a really important thing to address, that, you can do things, like, within, your office does things to fix some of the things that we've all been putting up with, because we're happy to be here. So.
Yeah, absolutely. I mean, it's
important,
and it's important to know there are things that we can do about it. And it's also important to know it's okay to be sad. It's okay to be frustrated that you have hot flashes and your life doesn't look the same that it used to. And I think what's missing is, like, giving women the resources, not just the medical resources, not just the medication, but having the discussion around, okay, how can we look at life? Like, yes, we're in a different place now, but how can we look at this differently, and what can we bring into our lives to make it as great and vibrant as it used to be, right? But in terms of medication, so there are non-hormonal treatments that we can do for hot flashes. The downside is that menopause brings about a lot of different things, right? It brings about hot flashes, joint pain, cognitive changes, fatigue, anxiety. So when I use hormone therapy, I have a lot, like that is going to check a lot of those boxes in terms of addressing them. Whereas with non-hormonal therapies, for example, our classic FDA-approved Brisdel, which is a selective serotonin reuptake inhibitor that's used for depression, but the dosage is actually not therapeutic for a depression dose that we use for hot flashes. But Brisdel is going to treat only hot flashes. So what I might do in that case is have a discussion around, okay, you're having hot flashes and you're having low libido, let's try Brisdel for hot flashes and let's do Addy for low libido. And we try things that way. And the other important thing that is extremely controversial but needs to be said is in some cases, we can safely do hormone therapy for women who have gone through these treatments. So there are people who really focus on this. It's always a discussion in conjunction with your oncologist. This is an area of medicine that I think is going to expand over time, but the conversation, my short thing that I will say about that is that the conversation is not just about you've had breast cancer, therefore you can never do hormone therapy again. It's every individual is different, and in some cases it's okay. So
Okay. Yeah, I know there has been a lot about it.
yeah.
In the past few years, there's been a lot of studies on it. So that's a
Yeah.
conversation that an individual, like she said, can come in and have with their office.
Yeah.
And so then I guess one more thing is sort of the last thing that we had to talk about was an overactive bladder.
Oh yeah. Yeah.
So I know that can kind of come with the territory. So
Yep. Same thing. So overactive bladder symptoms are often, in the context of this, are often going to come from that lack of estrogen. So the urethra sits right there at the opening to the vaginal canal, and it becomes affected. And so women, and also the muscles in the pelvis are affected as well. So we're often going to do our estrogen treatments, we can do our hyaluronic acid in that area, or pelvic floor physical therapy. The other option that's really helpful is oxybutinin. So we typically use that for overactive bladder, but if someone is having hot flashes, oxybutinin can actually be effective for hot flashes, and then we're kind of hitting two birds with one stone. So yeah.
Okay, great.
Cool.
Oh, it's so nice to know that there are options.
Yeah. Yeah.
So thank you so much.
Of course.
All right, I'm gonna end the recording now, but yeah.
Thanks, friends.